Assalamu alaikum. Good afternoon, everyone. Distinguished guests, my fellow colleagues. Uh, it's give me great pleasure to welcome to all today's satellite symposium on navigating HER2-positive metastatic breast cancer, current treatment landscape. I myself, Farhad Hussain Molla, Senior Sales Operation Manager of Oncology Division of Beacon Pharmaceuticals Limited. I would like to convey my heartfelt thanks to Oncology Club Bangladesh for organizing such an exceptional platform which takes oncology sector next level. And Beacon Pharma is always proud to be part of this from the very beginning. We're thriving embrace innovation in introducing the latest drugs at affordable price, ensuring the best quality and committing to improve every step of the way. On this session, also present here, my mentor and our all innovational activity behind the man, S.A. Mahmoud Haq Pallab sir is here. Special thanks to our leader is here, S.A. Mahmoud Haq Pallab sir. It's time to begin our first session. I am pleased to hand over the proceeding to our esteemed moderator, Dr. Lubna Mariam ma'am, who will be the guiding through the total sessions. Dr. Lubna Mariam Madam is one of the brightest minds in oncology. She has more than 15 years of experience on this field. And currently, she is serving as an Associate Professor, Radiation Oncology Department of National Institute of ENT, Bangladesh. We are fortunate to have such an exceptional professional leading this session. Once again, I welcome to all the session. Now I am requesting Lubna ma'am, please come on the dais and take their session. Thank you.
Thank you, Dr. Farhad, for a nice introduction. Honorable experts, distinguished guests, and fellow participants, Assalamu alaikum and very good afternoon. With immense pleasure, I, Dr. Lubna Mariam, welcome you all to the Satellite Symposium on navigating HER2 metastatic breast cancer current landscape. We are honored to have Dr. John Conibeer as our esteemed speaker. Let's give a small introduction of Dr. John. First of all, I'd like to say Dr. John is a friend of Bangladesh. Whenever we extend our hands, he answered, he responded. Besides, Dr. John is a deputy medical director at St. Bartholomew Hospital. He is also the deputy director of Barth Hospital. He had the central lead, Genesis Care Radiotherapy, Cornwall Hospital Oncology. He is also the clinical lead, National Lung Cancer Audit, UK. This interesting session will be chaired by our legendary oncologist of Bangladesh, Professor M.A. Hai. He is also my direct teacher, my mentor. He has 2 decades of experience, known for the extensive contribution to curative techniques and patient care in the field of oncology of Bangladesh. He is the ex-director of National Institute of Cancer Research and Hospital. He is the current director of Bangladesh Cancer Society Hospital and Welfare Home, and the president of this organization, this Oncology Club. Now, let us proceed with the main session, but before that, I'm excited to announce that we have a very exciting quiz section after the presentation with a special gift at the end of the session. May I draw your attention? The prizes is very interesting. There will be 5 prizes. First prize will be 20,000 taka voucher from the time zone. Second prize will be 15,000 taka Raymond gift voucher. Third prize will be the 10,000 Raymond voucher. Fourth prize, 10,000 time zone voucher. And fifth prize will be 5,000 Arung voucher. So stay tuned and focused on the presentation because the question will be from the presentation as well. So without any delay, I'm requesting Dr. John to come on the dais with the presentation and our visitor professor, Professor M.A. Hai, to chair the session. Sir.
So I'd just like to thank Oncology Club for once again inviting me to join you this year at your annual cancer conference, and I'd also like to extend my thanks as well to Beacon Pharmaceuticals again for kindly inviting me to present to you this afternoon navigating HER2-positive breast cancer, the current treatment landscape. So my disclosures, this afternoon, no scientific conflicts of interest to declare. And in terms of my talk this afternoon, so I'm going to begin by giving you an overview of HER2-positive breast cancer. I'm then going to focus on one of the unmet needs that we face in treating patients with this disease, and that's the management of brain metastases in particular. I'm going to talk about systemic therapies that we can use now to improve patient outcomes, and then I'm going to finish my talk on local treatments, and finally, some future options we hope to be able to offer patients further in time. So in terms of HER2-positive breast cancer, well, it makes up about 15 to 20% of breast cancer cases. As we know, HER2 amplification or overexpression promotes aggressive tumor behavior, and that unfortunately, if left untreated, leads to a poor prognosis in our patients. But I'm pleased to say over the past 2 decades, advances in targeted therapies have led to significant improvements in outcomes. When we think about HER2-positive breast cancer, we need to think about its family members. So there's 4 different family members. Essentially, it's a transmembrane receptor tyrosine kinase that can undergo either hetero or homodimerization, which then leads to phosphorylation and intracellular signaling. And unfortunately, it's the activation of those pathways which ultimately results in cell proliferation, tumor cell survival, differentiation, and invasion, which culminates, unfortunately, in a poor prognostic disease. If we look at common metastatic sites in breast cancer, take note that HER2-positive disease seems to have significantly higher rates of brain disease than other non-HER2-positive phenotypes. You'll also see that there's some increased incidence of lung metastases. Why is this important? Well, as we know, metastatic disease can have a dramatic and important impact on physical and mental symptoms that our patients face. So physical symptoms, it can lead to pain, disorientation, cognitive effects in terms of brain metastases, and that can obviously lead to emotional challenges, symptoms of depression and anxiety, and that's important to assess for and to treat in patients who we care for. If we look at the evolution of treatments, so you'll see here from the first line to third line studies that unfortunately, as you move through those lines of treatment, we see reduced efficacy falling away from an overall response rate of 80% in first line to only 40% in third line and beyond. And what's also important to note is that patients traveling those pathways, only approximately a third of patients will actually reach third line treatment. And so many of the patients whom we care for will pass away before reaching later lines of treatment. And in terms of treatment options, well, we've got traditional ones like hormone therapies, chemotherapy, but in HER2-positive disease, it really is the advances we've made in targeted therapies that has changed the treatment landscape, both in terms of antibody-based therapies, antibody conjugates, but also now tyrosine kinase inhibitors, oral ones. But there are things that we can offer patients beyond that. So there's interest in work being conducted on the role of immunotherapy in brain metastases. And of course, as a practice in radiation oncologist, I'm pleased and privileged to say that I can offer my patients access to advanced radiation techniques for treating brain disease. If we take a snapshot of where things are currently, so firstly in the early stage setting, we're all aware of the use of trastuzumab and pertuzumab with chemotherapy in the neoadjuvant setting. We have data showing the benefits of HER2 therapy combined with chemotherapy in the adjuvant post-surgical patients. And then in high-risk patients who've perhaps had neoadjuvant therapy, who have a failure to reach complete response, we now have data from the Catherine trial demonstrating the benefits of TDM1. In terms of the metastatic setting, so we've got the results of the Cleopatra trial that have formed our first-line therapy approach. We've now got data from the Destiny study looking at TDXD, but as we'll see later, we also have important data looking at the role of tucatinib in combination with capecitabine and Herceptin in patients with intracranial disease in that second-line setting. And then third line and beyond, we have oral tyrosine kinase inhibitors and, of course, TDM1. If we now focus our attention particularly on brain metastases, well, what is a brain metastasis? Well, here you can see one clearly demonstrated by that contrast-enhancing lesion in the parietal lobe of this patient's brain with associated vasogenic edema. When we look after patients who we have suspicion of brain metastases, it really is important that contrast is administered, as without contrast, the tumor can go unseen. And if we place patients through MRI scanners, what we've seen is that you can detect an increasing burden of intracranial disease through virtue of using more sensitive tests. Here you can see an MRI scan demonstrating multiple brain metastases, and that can happen often in up to 3/4 of patients who undergo MRI imaging. I think we're all aware that PET-CT is a modality of imaging that's not particularly helpful when it comes to detecting brain metastases. But even in some patients with a large intracranial burden, there is patterns of change in that FDG avidity that can suggest an underlying problem. But again, it's important to validate that with dedicated brain imaging. If we now extend the talk to HER2-positive breast cancer and brain metastases, it's important to consider that breast cancer, we've already heard today, is a significant burden on the cancer workload we face, and it's approximated that 1 in 7 or 8 patients will develop breast cancer. Patients who have HER2-positive disease, who go on to develop metastatic disease, it's estimated that between 25 to 50% of those patients will in fact develop brain disease. And what's also important to note is that the history of HER2-positive disease control, if we look back in time before the advent of Herceptin, because of the lethality of the disease, brain metastases weren't seen commonly. It's only through the advances we've made in extracranial disease control that brain metastases have become a problem due to that long-term and improved life expectancy these patients can face. So, who develops brain mets? Well, in my practice back in the UK, it always feels it's often younger patients. It's patients who've been on treatment for often a considerable amount of time. But don't forget that it is possible for patients to present in that first-line setting with brain metastases, although uncommon. As I alluded to earlier, it's a challenge. Patients have improving survival, so achieving good intracranial disease control is important because it maintains their quality of life and maintains their neurocognitive function and thereby avoids many of the unwanted side effects of intracranial disease. If we look at the results of the HERA-A trial, you can see here why brain mets poses a major challenge. So the blue and the orange line demonstrates the incidence of intracranial disease following HER2 exposure in the early breast cancer setting, so a significant burden. If we now look at the role of more advanced agents, so this is looking at TDM1 in the context of the Catherine trial, and even there where I've highlighted CNS disease still plays a significant burden on that patient group. If we think about the limitations we face in terms of conventional therapies, so many of the drugs that we do have limited penetration into the CNS tissues, what we describe as that blood-brain barrier that prevents them entering. And some of the drugs, unfortunately, have significant neurotoxicity, And of course, if drugs can't enter the CNS tissue, it provides a sanctuary site for tumor cells to evolve and develop resistance. ASCO has kindly provided guidance on the management of brain mets, so it doesn't recommend routine surveillance, but it does recommend a low threshold for imaging of the brain should patients have symptoms. And if those patients have metastatic disease that is controlled extracranially, the first question to ask is there a role for some form of targeted treatment for their brain disease without a systemic switch? But of course, if there's intra and extracranial disease progression, then it's important to think about next lines of systemic therapy. Which brings me on to those different approaches. Here you can see a slide demonstrating the different agents that we can use in treating patients with HER2-positive metastatic breast cancer, and I hope you can get an idea of how these different agents act either extra or intracellularly. If we begin our story of HER2-positive disease by first of all looking at trastuzumab and Genesis Slaman's pivotal studies, which essentially revealed that by targeting HER2 receptors with Herceptin, you could have a dramatic impact on patient outcomes. So here you can see the results from the HO648G study, and here you can see the M77001 study, which demonstrates the value of trastuzumab in those early studies with chemotherapy, demonstrating improvements for patients. We then saw pertuzumab arrive on the clinical landscape, which binds and stops HER2 receptors heterodimerizing. And so essentially it disrupts that ligand-dependent HER2 heterodimerization, which leads to intracellular signaling and thereby switches off an escape route that HER2-positive breast cancer cells can use when they're blocked using trastuzumab. If we look at the Cleopatra trial, which was a phase 3 randomized study of pertuzumab plus trastuzumab with chemotherapy versus placebo and trastuzumab, if we look at the endpoints in terms of PFS, you can clearly see the benefits that pertuzumab offered over placebo. And importantly, if we look at the overall survival from the Cleopatra trial, you can see a clear statistically significant benefit in survival, which led to that first-line adoption as a standard of care for this particular combination. If we now move on to TDM1, and more recently, the results of studies looking at TDXD, we'll begin first with Amelia, which was TDM1 versus lapatinib. And again, here you can see the value of an antibody-drug conjugate drug directed towards HER2 cancer cells, named TDM1, over capecitabine and lapatinib, a significant improvement in PFS. And again, the study Amelia demonstrated a significant improvement in overall survival versus capecitabine and lapatinib. When it comes to brain metastases, it should be noted that there are patients who can benefit with intracranial response through exposure to TDM1, but as we'll see later, we now have more effective treatments, for instance, tucatinib, which is leading the way in intracranial disease control. As I alluded to, we now have a new antibody-drug conjugate on the landscape, named Enhertu, TDXD. Essentially, it's a more potent antibody-drug conjugate with a high-potency topoisomerase 1 inhibitor with a specific cleaver that's cancer cell-specific, and also a very membrane-permeable toxin that leads to something we describe as the bystander effect, which I suspect is the reason behind the improved tumor control rates we've seen in patients with HER2 positive, HER2 low, and even HER2 ultra low disease. So essentially, it's a patent payload with a very specific point of entry with a high permeability of that toxic chemotherapy molecule. So if we look first of all at the Destiny Breast 02 study, this was TDXD versus treatment of choice. And what we can see here, a significant improvement in overall survival favoring TDXD. We now move to the more recent Destiny Breast 03 study, this time TDXD versus TDM1. Again, a similar story with a significant improvement in overall survival versus TDM1 in those patients pre-treated with taxane and trastuzumab plus or minus pertuzumab disease. It should be noted, though, that with these new, more potent antibody-drug conjugates, we're beginning to see side effects which we're possibly unaccustomed to, and that includes the new age of pneumonitis that we're beginning to see on the back of these more potent drugs. And so TDXD in the studies was demonstrated to have higher rates of pneumonitis, which is important to consider when treating these patients now in your respective clinics. And finally, we move on to the intracellular targeting drugs, so the tucatinib, neratinib, and lapatinib agents. So why are these agents important? Well, they, as the other drugs do, they target HER2 signaling, but they do so intracellularly, and because of their small molecular size, they seem to offer improved efficacy in terms of crossing the blood-brain barrier, leading to improved intracranial disease control, and thereby offering new options for treating brain metastases, which remains that important unmet need. In terms of tucatinib, well, we've seen and we'll see later that it has a high blood-brain penetration, which is efficacious against brain metastases. We'll also touch on neratinib, which again has demonstrated improved CNS outcomes in combination with other therapies in the advanced disease setting. And these studies, which we'll look at shortly, have demonstrated survival benefits to our patients. If we begin, though, with the first TKI, lapatinib, it's interesting to see that as a single agent, it only offers an approximate 6% overall response rate within the brain. And thereby it's been demonstrated by adding in capecitabine, you can improve overall response rate as demonstrated in these different studies. If we move and look at the EGF 100151 study, which looked at lapatinib and capecitabine versus capecitabine alone, here you can see that the combination of lapatinib and capecitabine did in fact improve time to progression, demonstrated by the purple line on this Kaplan-Meier curve. But we've moved beyond lapatinib. We're now in the age of next-generation TKI therapies, where tucatinib, a highly selective HER2-targeted agent with improved CNS penetrance, really has taken the crown. Here you can see the trial design of the HER2 CLIMB trial, which looked at the addition of tucatinib versus placebo to trastuzumab and capecitabine in previously treated HER2-positive metastatic breast cancer. Patients were randomized to either tucatinib or placebo. And if we move straight to the results, here you can see the results in patients. So in all patients with brain metastases, you can see by the blue line, the tucatinib arm, that those patients receiving it did have a significant improvement in overall survival and CNS progression-free survival versus placebo. If we focus our attention on those patients with active brain metastases, again, a similar story with a significant improvement in PFS and OS, so 64% reduction in risk of CNS progression or death, and a 51% reduction in risk of death, really stamping the benefits of tucatinib in this patient group. But also interestingly, if we look at the time to new brain lesions or death in all patients, you can also see that patients receiving tucatinib seem to have lower rates of development of intracranial disease, offering an almost CNS protective role of tucatinib. So to summarize in terms of HER2 CLIMB, it was a phase 3 trial assessing the benefits of tucatinib with trastuzumab and capecitabine, and as I mentioned, an almost 50% reduction in CNS progression with a significant improvement in median overall survival of 18.1 months versus only 12, which again led it to become recommended in both NCCN and ESMO guidelines. So both guidelines suggest we consider tucatinib, trastuzumab, and capecitabine for those patients we care for with active brain disease. So then the final TKI, neratinib, what is it? Well, it's a potent, irreversible inhibitor of HER2 and EGFR, so it has a pan-family coverage. It's been demonstrated to offer intracellular binding of these receptors, which is irreversible and leads to improvement in disease control. The agent has been studied in the NALA trial, which was neratinib and capecitabine versus lapatinib and capecitabine, this time in more advanced disease, and it demonstrated an improvement in PFS and delayed the time to intervention for CNS disease. Here you can see the cumulative incidence of CNS disease. You can see the blue line in the bottom demonstrating neratinib plus capecitabine, showing numerical superiority over lapatinib. And again, here you can see the benefits that neratinib offers lapatinib versus, in terms of PFS, again, with a numerically significant benefit. And finally, overall survival from the NALA trial again demonstrates a numerical superiority for patients receiving neratinib plus capecitabine. In terms of TKI toxicities, so I've selected this from the NALA trial. You can see here a higher incidence of diarrhea and nausea compared with lapatinib, which are the typical side effects we come to see our patients experience when receiving these agents. So we've also seen neratinib and its benefits in early breast cancer. I won't go on too much into this, but essentially the ExoNet trial, looking at extended adjuvant therapy for 1 year in early breast cancer following trastuzumab, did show a benefit for patients receiving neratinib. So it's important to think of those patients in future and whether they would be a candidate for extended adjuvant therapy using neratinib. So in terms of investigational drug combinations, I'm really pleased and excited to say that there's lots of studies taking place globally, looking at the potential future drugs we could offer our patients, whether that's targeting PI3K, the role of immunotherapy, but also the role of EGFR targeted drugs as well. So having talked about systemic therapy, I thought I'd then go on to the role of radiotherapy as a radiation oncologist and how we've evolved the landscape there also. So here we can see a typical patient undergoing whole brain radiotherapy with a homogeneous dose of radiation to the entirety of their brain. I'm pleased to say, though, that over the past 2 to 3 decades, there's been advances in brain radiation. So as we've seen in the systemic therapy space, where we've evolved and we've become much more targeted, the same has happened in radiation as well, where we've moved from a whole brain to a traditional conformal approach to now a stereotactic approach of delivering radiation. So what is stereotactic radiotherapy? Well, it's a highly geometric targeting approach to disease which offers superior accuracy. The radiation dose drops off quickly through high dose gradients, and you're essentially able to deliver an ablative dose of radiation to tumor deposits effectively and safely. It's been demonstrated to offer local control rates anywhere from 70 to 90% with low rates of radionecrosis. And as a consequence of that, it's been adopted globally as an approach to managing intracranial disease. There's studies demonstrating, like this one you can see, showing that patients with multiple brain metastases seem to benefit similar rates of long-term survival versus those with smaller burdens of intracranial disease. So here you can see the data from Yamamoto's study in the Lancet showing that patients with 1 tumor versus 2 to 10, there seems to be similar survival rates. So patients with multiple brain metastases should also be considered for this approach to treatment. We've seen evolutions in radiation technology when it comes to radiosurgery. Here you can see a traditional linear accelerator, but here you can see a machine specifically designed to perform this particular treatment called a gamma knife. And here you can see a patient who's prepared, ready to have that treatment delivered using a frame, which is affixed to the patient's head. But again, through the course of time, we've evolved and we can now treat patients more comfortably using a shell, a thermoplastic mold of their head and neck. We've seen the fusion of robotics to radiotherapy in treating brain metastases. Here's an image of a cyber knife, which we had in Barts. And in terms of accuracy, what am I describing? Well, I'm describing accuracy to a sub-millimeter level, so it really is precision radiotherapy. Here's a patient who's been treated with a solitary brain metastasis, moving from top left to bottom, demonstrating the evolution of response over time. Here you can see a patient, we treated a young patient with 17 brain metastases, each of which received an ablative dose. The treatment time, I admit, was long, but essentially we treated a small volume of that patient's normal tissue, thereby reducing the risk of late cognitive effects. And here you can see a patient we treated with 64 small brain metastases, each of them being below 1 cc, so that the total volume of all that brain disease was only 1.2. And what's interesting to note is that although every one of those brain metastases received an ablative dose, the patient's whole brain, their normal brain tissue, received only what would be considered a single fraction of their whole brain treatment. So it's through these advances that we've seen the uptake of SRS rise dramatically. Here you can see the patients treated in the US, but a similar story is in the UK and certainly in my centre back at home. So I thought I'd finish on future technologies for brain mets. So in our centre, now that we've got rid of our CyberKnife, we've moved on to something called HyperArc, which is LINAC-based and essentially allows you to treat multiple brain metastases in a much shorter period of time, thereby improving resources and cost efficiencies. But finally, there are other technologies coming into the marketplace. Here we'll see a video of a new machine called a ZapX, which essentially is an internally shielded radiotherapy delivery device designed to treat disease within the brain or neck. So what does that technology offer? Well, it means it's bunkerless, it can be placed anywhere. And I believe if you go to Japan, they have one in one of the Japanese central stations, so they're treating patients before they take their journeys across the country. So, to summarize, I hope today you've joined me in my journey through the HER2 treatment landscape. We've looked at the different systemic agents that we can offer our patients, and we've seen how over time, through the evolution of those agents, that brain metastases have become an increasing burden on our patient population through the successes we've had in extracranial disease control. We've seen how those different agents have been placed in ESMO and NCCN guidelines to describe how we should consider using them either in the early stage disease setting or within the metastatic setting. And we've seen how with the evolution of tyrosine kinase inhibitor treatments, we now have effective drugs like tucatinib that can cross the blood-brain barrier and lead to meaningful improvements in patient overall survival and quality of life. And it's with that I'd like to close my talk.
Thank you, Dr. John, for enlightening presentation. With your presentation, you guide us, and show us the path how to treat the metastatic breast cancer with the HER2 positive. Please take a seat, and thank you very much. We'd like to have some question from the audience. We know that all oncologists in Bangladesh, we have to deal with breast cancer, and metastasis is a big challenge for us. So how we treat our patient, these are big challenges, especially HER2-positive breast cancer, where there's so many limitations with financial toxicity as well. So how do you treat, how you treat the patient in your setting? That's we like to know also. But before that, just a small information that you all given a small QR code that we like requesting you to scan through your mobile, because after this session there will be exciting quiz session. So please do the scan of the QR code so that you can win the prize. So now I'm requesting, is there any question from the audience? Please, thank you. Mike,
Mesmerizing. The only word that comes in mind after Dr. John's talk. Thank you so much. It was really good. So, my first question. Normally, we don't do MRI for an asymptomatic patient to search for brain metastasis. But if a HER2-positive patient comes with liver mass or lung mass or bone mass, as per guideline, if the patient is asymptomatic, there is no recommendation of doing brain MRI. But I have seen in your center, in case of HER2 positive, if the patient comes with other metastasis, is there any indication of doing this MRI of brain?
So in my personal clinical practice, I do consider staging to be complete when that patient's had an MRI scan of their brain. So what I think is important, though, certainly in the United Kingdom, is if we discover brain disease, it means they're no longer able to drive. And therefore, there is a discussion I have with my patients about the potential impact on their ability to drive should we discover asymptomatic intracranial disease. What I've experienced in the past and what I've seen is where patients who've had brain disease discovered, they've then questioned why the MRI was done when they were asymptomatic, because no one warned them about the risk to their driving. And so I think that is an important discussion to have with patients before you do that scan.
Yeah. So my second question, you have shown us the HER2 study. So amazing result, hazard ratio 0.52, 48% reduction of risk of death. But if you look at the control arm, they didn't include the lapatinib that we use for a long time for brain mass. And we know from Emilia trial and the other trial that the combination of capecitabine and lapatinib does work. So I would like to know your thought on that. In one arm, no TKI, and in another arm, TKI, trastuzumab, and capecitabine. So if they had included the lapatinib in the control arm, would this hazard ratio could have been changed? Do you think that?
So I would have said that I suspect the arm would be different because we showed earlier studies demonstrating that lapatinib with capecitabine does cross the blood-brain barrier and does lead to disease control. But I suspect the results for tucatinib would still have been favorable versus lapatinib. So, but I take the point earlier about financial toxicity. So, you know, in the United Kingdom where I work, we have NICE, which very handily looks at the resource implications of drugs and thereby either funds them or doesn't, depending on the perceived benefit those drugs will offer the patients whom we treat. So my patients, I can offer them many of the agents that I've talked about this afternoon without having to think about the cost, because the cost is invisible to me and to that patient. But in health settings where the cost is visible and the cost will be placed as the burden on the patient, I take your point. It's really important that we consider this in the treatment and management options that we make.
John, I'm Professor Mofaddal. I treat a lot of breast cancer patients. A recent patient who was diagnosed with metastatic disease, HER2 positive, ERPR negative. She was on trastuzumab and pertuzumab. It continued for almost 2.5 years. She kept on doing well. Well, finally it became resistant, but unfortunately the patient shifted from my clinic to somebody else, and he kept on giving this pertuzumab and trastuzumab. After 6-7 months, the patient returned to me with brain metastasis, and I sent the patient to somebody for brain radiotherapy, and that particular point of time, I recommended for a second biopsy, because it has been a time elapse of about 2.5 years to 3 years. So by this time, the patient may not be remaining HER2 positive. There may be some biological changes. So she had relapse not only in the brain, but also in the lungs. In this particular case, what you will be doing? Will you go for a biopsy? Yes, I believe you will be going for a second biopsy, number one, to assess the HER2 status. Meanwhile, as she had lung as well as brain disease, what should be your choice? Before knowing the HER2 status, because it takes around 2-3 weeks to receive the biopsy as well as the HER2 status.
So to answer your first question, so in Barts where I work, we took part in the Destiny 02 and 03 studies. So they were patients who'd either had first line or second plus lines of therapy who were then entered for TDXD. So in those particular studies, one of the entry criteria was for a biopsy to confirm HER2 positivity, and that was centrally reviewed. So in the context of the clinical trial, all patients entered were confirmatory for HER2 positivity. In my clinical practice now, if I have a patient who's HER2 positive, who has metastatic disease, who's either transformed from early to advanced, then I wouldn't normally organize a HER2 biopsy. I wouldn't normally repeat a biopsy to reevaluate for HER2. Normally what I would do, I would switch their systemic therapy. So if they've progressed on pertuzumab and trastuzumab maintenance, depending on the pattern of the disease progression, I would then decide on whether a systemic switch or possibly targeted treatment towards their brain, so typically radiotherapy. So I think it is very nuanced in terms of the pattern of disease progression you face. For patients who've gone beyond the standard lines of HER2 targeted therapy that we can offer, then yes, I will consider a biopsy further on in that patient's pathway.
Thank you, the audience, for your questions. But just a small break. We'd like to hear from our legendary professor, Mihai sir, because he will leave for the namaz prayer. So I'm requesting sir to give your comments. Sir.
Thank you, Dr. Lumna. It was a very nice evening, afternoon. We have listened a very nice lecture from John. He is our old friend. Every time we call him, he is ready for us. So I have no comment. I cannot comment on his lecture. He has covered everything about this. So I thank you all very much for attending this course. The hall is full. It's very good. Possibly because of quiz. Maybe, inshallah, we play on quiz, and please forgive me. I will go for prayers. Thank you all very much.
Thank you, sir, for your time. We are very pleased to have you, sir, with us. So we will continue. We'll take 2 more questions, and then we'll go for the quiz session. Is there any more question? Okay, Dr. Bhaskar. Dr. John, will you come to the dais, please, and have your seat?
Yes, my question. My question is regarding the brain mets. If a patient has been treated with multiple lines of anti-HER2 treatment, and the next option is for tucatinib, And we know that tucatinib basically crosses the blood-brain barrier. And at that time, if he comes to us with brain mets, then what should be our option? Should we go for tucatinib? Should we continue tucatinib, or should we add SRS or things like that? Because in case of lung, we know that if we start that targeted therapy, we shouldn't give radiation therapy. So what's your option at that time?
So it's a patient with multiple brain metastases who's had multiple lines of therapy, is that?
Yeah.
So I would say, personally, if the patient has uncontrolled intracranial disease and it's beyond the scope of stereotactic radiotherapy, then I would look to use tucatinib, because I know it's more likely to have CNS penetrance and lead to CNS disease control. In the UK, when it comes to other antibody drug conjugates, so for instance, TDXD, the form that I have to complete to access that drug for that patient stipulates that they have to have controlled intracranial disease. So even though we've now seen data demonstrating that patients can respond intracranially to TDXD, it's not a treatment option in my center because NICE says it's not allowed to be used unless you've done some intervention to lead to disease control. In terms of, I think once you get beyond standards of care and you're into your 5th, 6th lines of therapy, which sometimes these patients can achieve because they're often young and they've got minimal medical comorbidities, then I think it's really looking at what the best options you have available are, but warning that patient that the likelihood of intracranial disease control is really, unfortunately, very small.
Professor Elahi, sir. Mic, please. Mic, please. Someone give. Okay, thank you.
Thank you, Dr. John. I have a patient now I am treating. She is a 49-year-old female. ER negative, PR negative, HER2 positive. She has received trastuzumab, followed by TDM1, and developed skin metastasis as evidenced by skin biopsy, extensive from trunk and back. So I have given her at present neratinib and capecitabine. Response is very good. But now I think after that, what will be my treatment if it recurs again?
So she hasn't had trastuzumab directed to TUCAN, so TDXD. So
Yes, TDM1, not TDM.
just so you could offer TDXD, but I
that is
imagine
not
the
available in our
financial
country.
toxicity of that is very high, or it may not even be available.
HER2 not available in Bangladesh and India also.
Okay. Then I would have said you could consider switching to tucatinib, as it has a different molecule, so you may find that she has disease response once more to that. And then after that, once you've exhausted your HER2 targeted therapies, I then move more onto more traditional treatments. So eribulin, for instance, something along those lines.
Thank you very much.
Thank you, sir, for your excellent presentation. Sir, seems like you are both excellent in chemotherapy, I mean medical oncology and radiation oncology. I have seen a lot of machines, that is promising machines. Sir, you have shown that in hyperarc therapy, multiple brain metastases are given in a single setting by a arc. But is it possible in linear accelerator machine having incorporated with SRS therapy or SBRT therapy, is it possible to do in linear accelerator machine which is enabled with SRS therapy?
So in our center back in Bath, so for over a decade, so historically, going back 2 decades, we had a gamma knife, and then the gamma knife was taken over by CyberKnife, And then in May of this year, we decommissioned our CyberKnife. And so in doing so, we then transitioned patients onto our Linacs. And so we now perform our SRS service using HyperArc on our linear accelerators. And so one of the concerns when we commissioned that service was the tumor size that the patient had. So in the United Kingdom, HyperArc centers had a cutoff, anything less than 1 centimeter, so 1 cc, those Linac centers wouldn't treat. And our lead physicist did a lot of QA and a lot of dosimetric work to look at the safety and reproducibility of using HyperArc to treat sub 1 cc brain metastases. And we were very happy with the results of his QA analysis. So we now routinely treat patients with sub 1 centimeter, very tiny brain metastases on Linac. And I think the highest number of patients we've treated so far is a patient with 38 very tiny brain metastases using HyperArc on a Linac. So it can be done, and it can be done safely.
Thank you, sir.
Thank you, audience, and thank you, Dr. John Conibeer, for an excellent, exciting presentation. And with this, the presentation session will be here ended. I like to ask all the audience, is it any problem doing the registration or QR code? Or you are all logged in with the QR code? All logged in, okay. Please help Professor Hussain, sir. There are many problems with the QR code login, please.
Dear doctors, I hope you have all got the QR code scan copy. I would like to request you to refresh the QR scan copy that you have logged in. Just refresh it if you logged in before. If you have logged in before, just refresh it and you will have shown in your interface that 10 questions. Can we start? Okay.
So we come with the first question. Tucatinib is classified as which type of drug? There is 4 options. Please, logged. Please choose your answer. You will get 20 seconds to answer every question. So it's been first question finished. Results is okay. It's TKI. 91% answer is TKI. Okay. We are going through the second question. Which percentage is at higher risk for HER2 positive in breast tumor? Which percentage? It was in the lecture. Highest number answer will be prized with an exciting presentation. Present. Yes, 67% presenter is with this. 67%, right? Okay. The third question is the name of the pivotal trial for tucatinib. The name of the pivotal trial is Destiny, Nala, Catherine, or HER2 Climb. Great. Okay. Next question, please. What is the main purpose of the sentinel lymph node biopsy in breast cancer? The answer, to remove the inside tumor, to determine if cancer has spread to the lymph nodes, to monitor the effectiveness of the chemotherapy, or to evaluate the patient's hormone receptor status. Which one? Click. Time up. The answer is 92% respondent answered correctly. Still the Sabrina. Next question, the most common side effect of neratinib. Options are asthenia, diarrhea, hand-foot syndrome, or fever. Time is ticking. Answer the question. Okay. The answer is diarrhea, 88% respondent correctly, and still it's Dr. Sabrina. Wow. Which receptor is not ERBB family receptor tyrosine kinase inhibitor? The options are HER2, HER3, EGFR, PIK3. You have to answer quickly. PIK3 is the right answer, 67% responded correctly. And still the number one is Russia. Okay, Russia, Dr. Russia. After surgery and neoadjuvant treatment of breast cancer, if residual remain, then which is the preferred option? The options are trastuzumab, TDM1, pertuzumab, and megatinib. It's a little bit difficult? No? Okay. TDM1, yes, this is the right answer. And the winner is the Samia Wahid. In the HER2 positive subtype of breast cancer, a diagnosis of breast metastasis is common, affecting how percentage of women with advanced disease. The percentage of the breast cancer, HER2 positive breast cancer with metastasis to brain. The percentage is 5 to 8%, 10 to 15%, none, or 25 to 50%. The answer is 25 to 50%. Samia Wahid. Present treatment algorithm of first-line metastatic breast cancer. Trastuzumab, pertuzumab, taxane, capecitabine, TDXD, or TKIs. Okay, the correct answer is trastuzumab, pertuzumab, and taxane. It was Samia Wahid. And last question. Tucatinib selectively inhibit HER2 without significant inhibition of other HER2 receptor, minimizing the side effects. Yes or no? Is it true or false? It is our last question. And we'll have winner, 5 winners from this session. So it's true, and we have the winner. Congratulations, all the winner. And so congratulations. We'll announce the name very shortly, but right now I want to request, I want to call up on the stage Mr. Paula Sharkar, Sales Operating Manager, to to talk about a few words from the Beacon Pharmaceuticals PLC. We also have with us Mr. S.M. Mohamedullah Haq Pallab, Executive Vice President, Sales and Marketing from the Beacon Pharmaceuticals. Yeah, okay. So, 5.5K. Oh, these are the top 5? So I'm requesting to come up in the dais the first five winner. First, the Samia Wahid. I'm very proud of you, Samia. SM Rokonuzaman also. I'm very proud of Rokon. Please come up on the stage. Dr. Shahida Alam, please come up on the stage. The Adnan Arifin and guest 803. I don't know any guest 803. Who is it? Who is guest? 803. Please, all of you, please come on the stage. Congratulations. We have to share with us. So now it's time to So I'm requesting Mr. S.M. Pallab to come on the dais to hand over the prize to the winner. Big hands to the winner. Please. First, Dr. Shahida Alam, Dr. Samia Wahid, Dr. Rokonuzaman, Dr. Adnan Arifin, and the name, please. What is your name, please? Your name, please? Dr. Baby Rani Pal, who was guest of 803. Quick. Please hand over the prize. First prize, guest 803. First prize. We'll start from the fifth prize, sorry. Oh, first prize, Samia Wahid. Yeah. Samia Wahid. Second prize, SM Rokonuzaman. Second prize, SM Rokonuzaman. Third prize, Dr. Shahida Alam. Second prize, Dr. Rokonuzaman. Big hands to Dr. Rokun. Third prize, Dr. Shahida Alam. Fourth prize, Dr. Adnan Arifin. Fourth prize, Dr. Adnan Arifin. And fifth prize is Dr. Baby Rani Paul. And a group photo.
We are almost very much delay. So just 1 minute, sir. Now I am requesting our Executive Vice President to hand over the crest to our speaker, John Conivier. And also our moderator, ma'am, Lubna Moniam, ma'am. Please, Arun bhai. This John.
Respected physician and my dear colleagues, good evening. I want to extend my deepest gratitude to our esteemed speaker, Dr. John Conivier, for your thoughtful presentation. Respected chairperson, M.A. Hai sir, our moderator, Lubna Moriam madam, and organizing committee for exceptional planning to give us opportunity as a part of this scientific symposia. And also I am grateful to our mentor, S.M. Mahmudul Haq Pallab sir, and my dear colleagues from Beacon Pharmaceuticals Limited. Our speaker share few important advancement treatment landscape for HER2 positive metastasis breast cancer, and TKI one of them. And I am glad to share you that going to launch 2 more TKI tyrosine kinase inhibitor, neratinib and tucatinib very soon. I hope both of drug added benefit for overall survival and improve the quality of life of cancer patient, and wishing your continued success and hope you soon all you future events. Thank you.